The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flightbridge Ed in their entirety. This is the Flightbridge Ed Podcast, critical care and emergency medicine education for nurses and paramedics.
Hey everybody, welcome back to the Flightbridge Ed MDCAST. I'm your host. My name is Mike Lauria. I'm an emergency medicine, critical care, and EMS physician with a special focus and interest in critical care transport. And today we are going to be talking about pulmonary embolism. So funny thing, I was getting ready to record this podcast a little while ago, and essentially, no sooner had I finished recording the podcast than the AHA and the ACC came out with a new set of pulmonary embolism guidelines. So this was the American Heart Association, the American College of Cardiologists, the American College of Chest Physicians, the American College of Emergency Physicians. Everybody got on board with a brand new set of guidelines. So back to the drawing board for the podcast. But the good news is you're getting this essentially hot off the press. These were just released in February 2026. So we're going to discuss these. All right. So pulmonary embolism, specifically high risk pulmonary embolism or pulmonary embolism with hypotension and approaching cardiac failure or shock, essentially. Why does it matter? And why is it important for critical care transport personnel? Well, I would say it is very, very important because the mortality is super high. So high risk PE, what we used to call high risk PE, maybe I'll refer to it as the entity formerly known as high risk PE, was a small percentage of all pulmonary emboli. Pulmonary emboli is a relatively common diagnosis in the emergency department, but only about 5 to 10% were the super high risk end, and were associated with things like hypotension, all sorts of badness. But that group had an exceptionally high mortality rate. So the 30-day mortality for that subset of patients was approaching 30 or 40%. So almost half of the patients that had really bad or really significant PEs that were causing low blood pressure, low perfusion of the organs, and shock, you were approaching an almost 50% chance of survival or 50% chance of mortality, depending upon how you're looking at it. But despite really clear guidelines, previously, not a lot of patients got reperfusion therapy at outside hospitals, which was a problem, number one. And number two, specific to transport, there's a lot of these patients getting moved because they're coming from smaller critical access hospitals, whether or not they actually get the appropriate therapy. And they're going to centers that can do ECMO or catheter-directed thrombectomy or other surgical interventions that require tertiary or quaternary care and an interventional specialist, interventional radiology or an interventional cardiology specialist to perform those procedures. And like I said, this is actually a pretty substantial burden. We're talking about upwards of 300,000 deaths per year. And actually, if you look at all comers, death from cardiac disease, the third leading cause in PE. So although across the spectrum of PEs, it's less common because there's a lot of PEs out there. The mortality rate is exceptionally high, and we're going to be moving a lot of these patients around at various levels of disease severity. So let's talk about how we define it. This is where it gets really interesting because this was a huge change in the current guidelines. Previously, we defined high risk or PEs based upon essentially their size. There were low risk and then submassive and then massive pulmonary emboli. Those were the old AHA guidelines. That was less helpful because, as it turns out, surprisingly, you'd think that the size of the clot or clot burden was directly associated with mortality. And actually, it's not. You don't necessarily have to have a giant clot to cause problems. People can have really big clots and show up with mild symptoms and minimal evidence of right heart strain. And people who get even smaller clots very quickly, suddenly, can have major, major issues. So it doesn't really correlate with clot burden. So the whole submassive, massive PE, that terminology was not super helpful. And the Europeans then came out with a set of guidelines that was a little bit more helpful. They used the terminology low risk, moderate risk, and high risk PE. And the high risk PE were essentially patients that had hemodynamic instability. So it really dealt with patients that, or characterized patients based on their hemodynamic profile and not how big the clot was. And that was really helpful for us because that did correlate with mortality. So essentially patients that had had a cardiac arrest, that had evidence of ongoing organ hypoperfusion or shock. So they had defined that previously as a blood pressure, systolic blood pressure below 90, or the requirement of vasopressors to maintain perfusion, plus some evidence of end organ hypoperfusion, acute kidney injury, liver injury, any of those things, lactate climbing above 2, anything else that showed the organs really hurting from this lack of perfusion. That was the high risk PE category that we previously used. And the biggest change was how the AHA and the ACC decided to classify PEs now. And this, I think, was a very helpful framework for a couple of reasons. They changed, and I should also point out that the European guidelines took that submassive group, that middle group of like, they're not fine, they can't go home, but they're not hypotensive and dying, that moderate or intermediate risk group. And they basically divided it up into higher risk and lower risk. So even within the intermediate risk group, there was essentially 2 categories. So overall, there were kind of like 4 categories in the previous European designations. But now the AHA and the ACC came out with 5. And I like this for a couple of reasons. One, it's a particular upgrade from the original definition. The categories that they have are essentially category A, which is subclinical or incidental PE with no symptoms. So these patients are fine. And the big debate here in the larger picture is, do we even need to anticoagulate these people? The symptomatic patient, so there's relatively low clinical severity. So we're talking like subsegmental PEs, small PEs that have symptoms. But if we use a clinical severity score, and some of those scores may be something you may have heard of or may hear getting thrown around. So a PESI, so a pulmonary embolism severity index, or SPESI, they're abbreviated or shorter tools that we can use to risk stratify these patients. They always fall out low risk. They're not super tachycardic. Their symptoms aren't that bad. Their oxygen saturation is fine, so on and so forth. Category C, these are patients who are symptomatic, but they do have some evidence of heart strain or other issues going on. So they're not hypotensive, but if you do the usual cardiac blood test, their troponin might be elevated, their BNP might be elevated. If you do some echocardiography on them, you may see some evidence of right heart strain or dysfunction. So either biomarkers or evidence on echo that their RV is not happy, even though their blood pressure might be normal. That's group C. D is a category that they called incipient cardiopulmonary failure. And these are the patients that have objective hypotension. So their blood pressure is low. I think they still use the systolic blood pressure to define hypotension in this group. But you can essentially think about it as anybody with a systolic blood pressure less than 90. Or you can also, I think it's reasonable to use the MAP less than 65, but I think the AHA used systolic blood pressure less than 90, and evidence of end organ hypoperfusion. So specifically a lactate greater than 2, acute kidney injury, urine output that's less than half cc per kilo per hour, mental status changes, or if you have a SWAN in them, cardiac index less than 2.2. So any of these things that they used would categorize you as category D, and then category E, which is essentially florid failure. So these are patients in significant shock, so recurrent or persistent hypotension and cardiogenic shock, plus or minus they've actually had a cardiac arrest. So those are the 5 categories. What we also like about it, if you've heard me talk at any of the conferences or anything else about cardiogenic shock, these categories kind of match the SCI categories for cardiogenic shock. Now, the Society for Cardiovascular and Angiography Interventions, SCI, was involved in the development of these guidelines. I haven't talked to anybody from the AHA or SCI or anything else to see if this was on purpose, but I have to imagine it was somewhat influenced by that model of cardiogenic shock. So I think it is very helpful in the sense that it's like parallel to that idea of cardiogenic shock, and that's what we really care about, right? Because the thing that kills people with pulmonary emboli is not hypoxia, it's not shortness of breath, it's essentially right ventricular failure. That's what kills people. Now, on that topic, we should probably get down to the pathophysiology and discuss the pathophysiology of these groups we'll call category D and E pulmonary emboli, which is right heart dysfunction. So if we want to understand how we can help support these patients, it's important to understand what's going on. And really, again, I can't hammer home enough, it is usually less so hypoxia, shortness of breath, or problems ventilating with these patients. The big problem is they feel that way because their RV is failing. If you think about it, the right ventricle is really designed as a low pressure system, right? The pulmonary arterial pressures are normally in the low 20s, so 20 to 25 over like 10-ish is the blood pressure in the pulmonary circulation, and your systemic circulation is like 120 over 80. And with a lot of people, it's usually higher, 130s, 140s over something. So your LV can generate a pretty big pressure head. Your RV really can't. It's designed to push through a relatively small and low pressure circuit or low resistance circuit right over to the LV. So I kind of think of that as like, the left ventricle's like a Dodge Ram 3500 Cummins diesel that can pull 20,000+ pounds. And the right ventricle is kind of like a little Mazda Miata. It can go pretty fast, but not that fast. And it's not used to hauling or pulling a heavy load. And so if I took my travel trailer and hooked it up to that Mazda Miata, it would be on the struggle bus, man. That engine would just like melt down. And so it's really not used to, the right ventricle is not used to substantial increases in afterload. It can't push that hard. Under normal conditions, sometimes it can go up to systolic blood pressures in the 30s and 40s, but it's really not designed to do that. And so anytime you have a significant increase in RV afterload for whatever reason, it will be on the struggle bus. It'll be really, really hard. So large increase in pulmonary vascular resistance causes major problems. So it kind of starts out like this, right? The pulmonary arterial pressure rises, so the resistance goes up because now there's a big goober, there's a big clot in the pulmonary arteries. The pulmonary arterial pressure starts to rise. That backs up volume into the right ventricle, and the right ventricle starts to dilate out. And as that's happening, the pressure in the right ventricle is starting to rise. As the RV dilates out, just like the LV, the contractility gets worse. So both the ventricles operate on a happy little curve where they need to be full to generate appropriate stroke volume. But if you fill them too much, if you overstretch them, kind of like an overstretched spring, they actually don't rebound or contract nearly as well. And that causes a couple things. So number one, as that RV gets bigger and bigger and bigger, it kind of encroaches, it pushes on the LV. Because remember, as the left ventricle is filling in diastole, it's not really a high pressure circuit, right? In diastole, it is a relatively low pressure circuit. And so if that RV is bulging out into the left ventricle because of very high right-sided pressures, pressures that were normally like 25 over 10, now they're 40 over 20, 50 over 30, something like that. That causes essentially a decrease in the real estate in the left ventricle. It can't fill up as much. So the stroke volume gets super tiny. So that's problem number one. Problem number two is when that RV stretches out. I think of it kind of like a towel that gets wet. When you twist it and wring it out, all of the liquid water comes out of it, right? Well, when the wall tension in the RV is so high that it exceeds the systemic blood pressure, then the RV is not getting perfused, or at least the perfusion is very limited to the RV. That really sucks because the RV is already on the struggle bus, and now the blood can't really get through to the muscle and feed it. So you got a double hit. It's like a 1-2 punch on systemic blood pressure and perfusion to the RV. So cardiac output falls, right? Because if you have a lower stroke volume in the LV, now it's squeezing out only 20 or 30 cc's instead of 60-ish cc's per squeeze. Cardiac output goes down, and the already struggling right ventricle gets essentially less blood flow. In addition to like systemic shock, right? All of your organs feel it. The RV is definitely going to take the hit. I would also add something very important here, which is, if you've ever heard a talk by Sarah Krager, she's an emergency physician and intensivist as well that primarily focuses on focuses her work in the cardiac ICU. She has a really funny way of explaining it. She calls the RV a perfusion princess. So the RV is actually used to getting perfused. We always say the left ventricle gets perfused in diastole, while the RV actually gets perfused in systole and diastole. And the reason for that is if your systemic blood pressure is 120 over 80, that means your diastolic pressure is 80. And your systolic blood pressure is 120, right? The pressures in the RV are 25 over 10 or 12-ish usually, which means that there's consistently enough pressure in the pulmonary, in the systemic circulation and in the coronary arteries to perfuse the RV all the time. So it's used to getting all the blood flow it wants all the time, and all of a sudden you cut that off significantly. That makes it even worse. And so as it gets worse, it dilates out more. It can't contract even more. So it's pushing less blood into the LV, and the LV has a limited chamber filling because the RV is bowing into it, and the LV can't push out, and then you get more hypotensive. And then as you get more hypotensive and the RV is more on the struggle bus, it just gets worse and worse and worse. And this is what we call colloquially that RV spiral of death, or the PE death spiral, some people will call it. So our whole goal is to support the right ventricle in this patient cohort and support them and make sure they have systemic circulation or systemic perfusion and perfusion to the RV so that they can get the definitive care that they need, or the ongoing care that they need. Now, I think it's worth mentioning at this point that even in the less severe patients, one of the mainstays of therapy, even if they're awake and they're just symptomatic and they're getting transferred to a hospital with an ICU or cardiac intervention, anticoagulation is like the mainstay of therapy for these patients because we don't want that clot getting any bigger. One of the very interesting changes in these current guidelines was the switch from a recommendation and the initial parenteral anticoagulation. So IV, sub-Q, basically not PO, not by mouth anticoagulation, which is what these patients are initially going to get, was actually low molecular weight heparin, so Lovenox. I'm sure we're all used to taking patients that have had STEMIs or have had PEs and they'll be on a heparin drip. Well, that might actually change. We may be seeing less of that because more and more of these patients, I think, based on these recommendations, will be on Lovenox and fewer will be on heparin. So heparin's second line or Lovenox is recommended above heparin. So it's nice for us logistically because we don't have to switch over the pump or take someone on an infusion. So you may be seeing that more and more. The guidelines also came with some interesting recommendations about outpatient therapy. So when these patients go home in their anticoagulation, all super cool, but I won't be reviewing that necessarily here as it's pertains less to what we're going to be doing in the transport environment. All right. So here's the meat and potatoes, right? The initial resuscitation. These recommendations have not changed too much. But I think it is important to go through over this because, again, if I could summarize this in one line, it's all about supporting the RV. And how we're going to support the RV is, number one, make sure that it's getting the perfusion that it needs. So make sure, the way we're going to do that is pretty straightforward. This is like bread and butter transport critical care, right? We're going to be managing their MAP, specifically keeping their MAP above 60 to 65. I would, for ease and for keeping things essentially in line with a lot of the other stuff we do, I would just shoot for a MAP of 65. The guidelines do discuss anything below 60 as a potential sign of okay, let them go down to 60 before we really consider it hypoperfusion. I actually would be a little more conservative, and my opinion is that just shooting for a MAP of 65 is the way to go. How do we get there? I think norepinephrine is probably the first go. It makes it easy. We're very facile. We're very familiar with norepinephrine. This is going to help improve that systemic blood pressure and therefore improve your coronary artery pressure by essentially increasing resistance in the circuit, by increasing the afterload. And there is some beta effect from the norepinephrine, which I think is helpful. Theoretically, there's discussion about vasopressin being helpful because there are fewer vasopressin receptors in the pulmonary circulation. So it's primarily a peripheral squeeze that you get as opposed to any sort of additional pulmonary vascular resistance. However, that's largely theoretical, and in the setting of RV dysfunction or RV failure, the reason why I think it's okay to basically say norepinephrine is the default, because I do want a little bit of beta. I do want a little bit of support for that right ventricle. So generally speaking, norepinephrine is where I'm going to start. Now, our other bread and butter ticket item for increasing blood pressure is fluid resuscitation. And with this, you should be very cautious. This is a change from what we normally do in sepsis and a lot of other things where we give people lots of fluid, or we say, like a fluid bolus won't hurt them. Well, in this case, it might. Fluid resuscitation, you should approach with a significant amount of caution. Too much fluid can actually worsen RV dilation because now you're trying to jam more fluid into an already distended, overfilled, and struggling right ventricle. That can actually have the opposite effect. It can decrease cardiac output. If there's really good evidence that someone's been sick for days or they haven't been able to eat or drink for days, and there's objective evidence that, their IVC is completely flat and you can't even see it, or there's other evidence that the patient may benefit. Okay, if you want to try a little bit of fluid, like a small bolus of 250, maybe 500 at the most, I would probably start out with 250. Okay, but aggressively just, like hanging a leader and let it go and saying, well, a fluid bolus won't hurt them is probably the wrong answer. I would discourage people from aggressive fluid resuscitation. If you get to an outside ED and you've heard that they've had, already had a leader and they're telling you the story about a bad PE with significant right heart strain and objective evidence of hypotension and RV dysfunction, I would be hesitant to continue any fluid resuscitation. In fact, if I saw another leader hanging, I would probably stop it and discontinue it. Likewise, if they're on the naturopathic, maintenance fluid, whatever we call it, I would just stop that. I would just discontinue it. It is probably not helping and may actually be harmful. Okay, so we're essentially optimizing perfusion to the right ventricle by making sure their MAP is appropriate and the pressure going through the coronary arteries perfusing that RV is optimal. The next thing that I think about is essentially in any patient with heart failure is decreasing preload. In this case, it's less important. I would not, especially in a patient who is in shock, I would be very cautious and be talking to the sending and receiving physician about diuresing these patients or managing their preload and optimizing their volume status as their MAP is in the toilet. I would probably not do that in this acute setting. Eventually in the ICU, we kind of get around to it, but I don't think there's a lot of utility in this case. It's going to take a while for it to work. Often these patients have some degree of developing or already developed kidney injury, and taking away volume in the setting of acute hypoperfusion and shock is probably not a great plan without having a lot of other data points that you can watch carefully. So I wouldn't send the patient to a high-speed wobble during a transport by giving them lots of diuretic. However, managing their afterload is absolutely something that will help, because remember, this is really a big-time afterload increase on the RV, and that's kind of the nature of the problem. I always foot stomp this. Remember that oxygen is essentially the OG pulmonary vasodilator. Hypoxic vasoconstriction in the pulmonary arteries is absolutely a thing. So if the patient's, sitting in like the low 80s or the high 80s, low 90s, you may want to bump them up to the mid 90s. How we do that is essentially all, I would say, non-invasive, if at all possible. So regular nasal cannula, non-rebreather mask. High flow is a great tool. If you guys have it in your armamentarium, using high flow nasal cannula is fantastic because you can do number 2 with it, which is actually provide an inhaled pulmonary vasodilator. So both nitric oxide and epoprostenol can go through a high flow nasal cannula. You have to be careful because normally the high flow nasal cannula can go up to 60 liters of flow and 100%. At those flows, my understanding and interpretation of the literature and currently how most hospitals have their guidelines is they limit the flow on high flow nasal cannula when you're delivering epoprostenol in particular to about usually no more than like 30 liters per minute. I've heard of some places going up to 40, but really I think of like 20 to 30 is like the high end, because if you go much faster than that, if the flow is much higher than that, the epoprostenol as it hits that the aerogen, it's basically not quite a nebulizer. It's a nebulizer, but it doesn't work like the regular cup nebulizers. It creates a very fine mist. It can't create that mist or that nebulization fast enough, and you're really not delivering the epoprostenol that you want to their lung parenchyma. So there are some limitations on some of these agents in terms of, you can't go too high on the flow, but it's a great way to do it because increases in positive pressure, i.e. putting a patient on BiPAP, CPAP, or intubating them can be pretty dangerous because that's adding to the RV afterload issues, increasing pressure in the lungs and thorax. Positive pressure in the setting of already high RV afterload can be pretty dangerous. It can cause sudden deterioration in their blood pressure and cause major issues. So I think all of us, whether it's myself in the ED, the ICU, some of our anesthesiology colleagues, we will try to get people through this phase of their disease and get them to what they need without intubating them. In fact, some institutions would sooner put someone on ECMO than they would intubate them. That's like how bad that RV, that increase in RV afterload from positive pressure can be. So I know that's hard when you're at an outside hospital or something without that capability. If you're at a critical access hospital or smaller institution and they just want you out the door, and they certainly don't have access to ECMO, just think about it like, I would recommend people think about it like this. The whole reason that we try to let people go ahead and not intubate them is because that increase in positive pressure, right? Well, we are letting them essentially compensate on their own if they can no longer compensate, i.e. they're getting tired, they're not moving a lot, they're getting like short, tiny little breaths, they're not ventilating well, they're not oxygenating objectively, their sats are dropping despite support with high flow nasal cannula, or they're just starting to get really, really tired and sleepy as they get more and more into this dense shock state. At that point, they really can't compensate. They can't maintain their oxygenation. They can't maintain their ventilation. And those are going to have direct consequences on that RV afterload, right? So specifically, the hypoxia can cause hypoxic pulmonary vasoconstriction, which can make the afterload worse, which makes the effects of that PE even worse. And so that is when I would consider it. Really, I try and think about it as like, can they maintain their airway and respiratory drive? If they can't, and we have to do it for them, that really stinks. But we have to proceed with a whole lot of caution. But it may be necessary at that point because they may not be able to maintain it on their own. So that's when I think about intubation, when they no longer can compensate and have failed other less invasive therapies. Getting back to what we were originally talking about, which is essentially that oxygen, epoprostenol, nitric oxide, they're all inhaled gases or agents that reduce RV afterload. So we started out by perfusing the RV. We're not going to diurese them or take any preload off the RV at this point like that, but we will decrease RV afterload using those agents. And then next is essentially going to be supporting the RV, so increasing RV inotropy. This is where I'd add epi or dobutamine. Almost always it's going to be epi in this setting. If you're already on norepinephrine and their RV is really on the struggle bus, starting out with like a low dose epi. I do not titrate it in cardiac patients the way I might in a septic patient or in the medical ICU where you're just like going up and up and up on it. There is what we consider the inotropic dose of epinephrine. So there is limited evidence in this setting. It's mostly bench research that suggests that once you get above, somewhere above 0.06, 0.08, upwards to maybe like 0.1, you start to lose a lot of the inotropic effect. And we do see significant increases in systemic vascular resistance. So it acts more like a vasopressor rather than an inotrope. So generally what I tell people, because those numbers are based on bench experiments, and we really don't know exactly in humans where the cutoff is. To keep the math easy, I just think, start the epinephrine, trying to keep it less than 0.08 to 0.1, somewhere in that range. If it's in the single digits, like 0.01 to 0.09, you're probably okay. And that can support the RV. So give it a little bit of inotropy to help it out. And lastly, we are going to start or continue therapies that are helping with reperfusion. So optimize the MAP, number one. Number two, we thought about maybe optimizing the preload, but really that is not the mainstay of therapy, so probably not in this case. Number three, decrease RV afterload. Number four, increase inotropy and help support the RV. And number five, try and get to the bottom of the problem. Think about reperfusion therapies. Most of the time at outside hospitals, or small critical access hospitals, we can't or don't have access to things like catheter-directed thrombolysis or mechanical thrombectomy, certainly not surgical embolectomy, or ECMO. So that leaves essentially the mainstay of reperfusion therapies, which is systemic thrombolysis. So this is guideline recommended. So essentially reserved for category D and E patients, meaning significant hemodynamic instability or cardiopulmonary failure. The guidelines do note that certain category D patients with impending or worsening shock may benefit from some of these therapies, specifically systemic thrombolysis, but it's not free and it has a fairly high risk profile. So for patients with significant PEs, so category D and category E PEs, it is the first line reperfusion therapy, especially for category E. The thrombolytics will rapidly dissolve a clot. They will bust up fibrin and break down a clot relatively rapidly, which will reduce pulmonary arterial pressure. And sometimes you don't need to get rid of the whole clot. You just need to get like a little more space for the blood to get by. So common agents that are used are alteplase or TPA, tenecteplase, TNCase. And as it turns out, a lot of times they're dramatically underused. So there's some evidence that says that if you look at all the PE patients, how sick they are, and if they had any contraindications to systemic thrombolysis, only about a third of eligible patients get thrombolytics. Yikes, that's kind of crazy. So only a third of the people that were eligible and didn't have any contraindications and had an indication to give it actually got it. So we're trying to increase awareness about this and say, yes, there can be a lot of complications. It's not the safest medication, but when you look at the overall risk-benefit profile from someone who's dying from RV failure, it may be worth it. And in fact, the risk-benefit may weigh in fact of giving this relatively high-risk medication. So, and in some cases, I've absolutely seen it take someone who is in florid shock to basically, like Drano for the pulmonary arteries, just clears it out super quick. And the next thing you know, they're like almost off pressors. I've also seen the reverse side of the coin where there are serious bleeding complications, but that is part of the risk that you take. So this is also important because occasionally the alteplase in particular is given as a bolus and then an infusion. So you may have to take a patient who's still on the infusion of thrombolytic medication. The tenecteplase or TNK is just kind of given as a bolus. So you should be aware of if it's been given or if there's an ongoing need for an infusion, depending upon the medication. Then you really got to look out for the major complications. Bleeding, of course, is the number one complication. So major bleeding is the most frequent complication in patients that are getting systemic thrombolysis, not surprisingly. So these can include things like intracranial hemorrhage, GI bleeding, retroperitoneal bleeding, bleeding from their spleen, liver, ribs, or chest if they've had CPR and then they get for any period of time and then get thrombolytics. They can get hematuria, they can get hemoptysis, or bleeding coming up through an endotracheal tube or coughing up blood. The rates overall, if you look at all the trials, the major bleeding is reported somewhere between like 10 and 20%. So all those things that I talked about would be considered major bleeding. So it's not insignificant. The big one, the big, bad, scary one that I can't treat or is I can't directly treat or is very hard to treat and has very significant lifelong sequelae would be intracranial hemorrhage, right? You start bleeding into your brain. That's not something that's easily controllable in the emergency department, the ICU, or in flight, and it can be lethal. It's certainly higher risk in some patients, so in patients that are older, so anytime you get above the age of 65, if they've had a prior stroke, a baseline hypertension, if they're already on anticoagulation and they get this, if they get thrombolytics, or any sort of recent surgery trauma, and specifically in this case, I would say the most common trauma is iatrogenic. It's from chest compressions, and that is something we should take into consideration. But intracranial hemorrhage, if we're talking about that specifically, it's less common, only occurs about 1% to 3% of patients who actually get systemic thrombolytics. But it is by far and away the most catastrophic complication. So patients may complain of headaches, they may get altered, they may have focal neurological deficits, so right-sided weakness, left-sided weakness, paralysis, or even seizures. And the mortality, if they bleed into their brain and when they've gotten systemic thrombolytics, is high. It can exceed 50% in some series, and some studies actually suggest it's very high, like above 50%. Luckily, it's less common, only about 1% to 3% of the time. You can also see things like as the pulmonary arteries are reperfused and they open up, they've been injured to a certain extent or have had low blood flow past them, and they get the blood flow, which can lead to some actually hemoptysis. They can get some mild bleeding. Occasionally, you'll see significant pulmonary hemorrhage. I think I've only seen that really once or twice, but you can get some hemoptysis. And then you see some minor bleeding. They can get nosebleeds. They can bleed from around their teeth. You can see oozing at some of the IV sites or bruises popping up someplace that didn't have bruises before. So be on the lookout for all of that stuff and document it. All right, so we essentially went through and we talked about major indications or why it's important for us to be aware of these patients. These patients are often getting transported for advanced therapies, whether that be ECMO or mechanical thrombectomy or whatever. So we're going to see these sick PE patients. We talked about specifically those categories and really foot stomped the new categorization from the AHA and the ACC. No more massive, submassive, high risk, low risk. It's category A, B, C, D, and E. D and E being the sickest, most important ones. We went through and talked about that RVPE spiral of death. And most importantly, we went over really sort of the management of these patients. A lot of it is going to revolve around managing acute RV dysfunction and failure. And how we're going to do that is we're going to maintain their MAP, usually with norepinephrine, avoid fluids, make sure we're oxygenating them well, and those pulmonary arteries are nice and relaxed. There's no pulmonary hypoxic vasoconstriction. Considering adding on an inhaled pulmonary vasodilator like epoprostenol or nitric oxide to reduce the RV afterload, give them some inotropic support with often epinephrine, but sometimes in certain circumstances, dobutamine might be a very reasonable option. And then really getting to the heart of the matter, which is reperfusion therapies. So asking about if they're a candidate for systemic thrombolysis at the sending facility, that they can either just give as a bolus or start and you can continue it, because a lot of the patients who are indicated don't necessarily get the therapy. And then watching out for complications of this therapy. So that was a review of the latest and greatest, and specifically the new guidelines and categorizations around pulmonary embolism. As always, everybody take care, stay safe out there, and we'll talk to you soon. Bye-bye.
This has been a production of the FlightBridge Ed podcast, leading the way in pre-hospital critical care and emergency medicine education.